Welcome. We're going to tackle a really interesting clinical puzzle today, one you'll definitely see on your boards: coronary vasospasm. It's this whole situation where a patient has all the signs of a heart attack, but their arteries are totally clear. So let's get straight to the high-yield points and crack this case together.
Okay, so let's start with something we all learned on day one. You see chest pain, you see ST elevation on an EKG, and your brain just automatically screams, blockage, right? It's a reflex. But what happens when you rush that patient to the cath lab and there's nothing? No blockage at all. Let's dig into that.
So here's our game plan. We're going to walk through this like a real case. We'll start with our puzzling patient, investigate this so-called phantom blockage, then figure out how to diagnose the spasm, talk about calming the coronaries, and of course, wrap it all up with the must-know PANCE prep points.
All right, first up, our puzzling patient. The story you're about to hear is just packed with buzzwords. Seriously, recognizing the specific clinical picture is the absolute first step to nailing this question on your exam.
Okay, look closely at these clues. These are the classic buzzwords. We've got a woman, typically under 50. Her chest pain happens at rest. And this is key. It often happens in the really early morning, waking her up from a dead sleep. This is the complete opposite of your typical exertional angina patient, right? This profile is your big flashing sign to start thinking vasospasm.
So then you get the ECG, and boom, you see ST segment elevation. And it looks, for all the world, like a STEMI. I mean, this is a critical finding. It's screaming transmural ischemia, a full-thickness injury to the heart wall. So naturally, all the alarms are blaring, and the cath lab gets activated stat.
So the whole team rushes the patient to the cath lab, fully expecting to find a big, nasty blockage. But what they find, or I guess what they don't find, is really the central mystery of this whole condition.
And here it is, the big twist. The angiogram comes back totally clean. Normal coronary arteries. No significant obstruction. Just think about that for a second. You have the symptoms of a heart attack, you have the EKG of a heart attack, but the arteries look perfectly fine. This is the central paradox you absolutely have to recognize for the PANCE.
And with that, we've unmasked our culprit, Prinzmetal angina. You'll also hear it called variant angina. The key thing to remember here is that this is a functional problem, not a structural one. The artery isn't blocked with plaque, it's just temporarily spasming shut.
You know, this table right here, this is your money slide for studying. It just perfectly lays out the difference between classic angina and this vasospastic kind. I mean, look at the key differences. Fixed blockage versus a temporary spasm, pain with exertion versus pain at rest, and the big one for your exam, ST depression versus ST elevation. Knowing this table cold will save you so many points.
Okay, so we know what it is, but in a real clinical setting, how do you actually lock in that diagnosis? Let's connect the dots and look at the clues that really confirm our suspicion.
The diagnosis really comes down to this classic triad. So first, you've got that chest pain at rest. Second, you see transient ST elevation. And that's a huge word here. It means it's there during the pain, but it goes away when the pain resolves. And third, everything gets better and fast with some nitroglycerin. That rapid response is a massive clue.
Now, this is where your history-taking skills become super important. You have to ask about these triggers. For the boards, smoking and cocaine use are the two huge ones. But don't forget to ask about things like severe emotional stress or even just exposure to cold. Finding and getting rid of the trigger is always step one in management.
So we've got the diagnosis. Now what? How do we treat it? And more importantly, stop it from happening again? Well, the management strategy is actually very logical.
Yeah, it really boils down to this simple three-step plan. Step 1, avoid. Get rid of those triggers we just talked about. This is totally non-negotiable. Step 2, treat. For an acute attack, sublingual nitroglycerin is your best friend for rapid relief. And step 3, prevent. You've got to start long-term therapy to keep those future spasms from happening.
So what are we going to use for that prevention step? Well, the two main players are nitrates and calcium channel blockers. Nitrates are great because they can stop an attack right now and help with long-term prevention. But for that daily preventative therapy, the real workhorses are your calcium channel blockers. They block calcium from getting into the smooth muscle cells of the artery, which causes them to relax and vasodilate, exactly what we need to stop them from spasming.
Okay, stop. Listen to this. This is a massive, high-yield, 5-star PANCE alert. Beta blockers, which we use for, like, everything else in cardiology, are a terrible idea in pure vasospastic angina. And you need to know why for the exam.
If you block beta-2 receptors, which help dilate arteries, you're left with unopposed alpha-1 stimulation. And what does alpha-1 do? It constricts, it clamps down, so you can actually make the vasospasm worse. I promise you, this is a classic test question.
All right, let's bring it all home. We're going to consolidate this into the most important high-yield points for your exam. Think of this as your digital flashcard section.
Honestly, this quote right here, this is the entire case in a nutshell. If you can just burn this one sentence into your brain, you will recognize the vignette every single time it shows up. Younger patient, pain at rest, ST elevation, and normal arteries on the cath. That's Prinzmetal. Period.
And here's your final checklist for diagnosis. If you've got these 5 things, you've got your answer. It's pain at rest. It gets better really fast with nitrates. The EKG shows ST elevation that comes and goes with the pain, and of course, that clean angiogram. It's a pattern, and once you see it, you'll never miss it again.
And we'll end on this thought, just to get you thinking. This condition is such a powerful reminder that a clean angiogram doesn't always mean a healthy, risk-free heart. It really challenges us to think beyond just anatomical blockages and to consider the dynamic, functional side of how our coronary arteries behave.